Hi guys, welcome to the hematology section of this app. I'm very sure you would have completed the hematology from pathology and now you're checking out this section. So the discussion that I'm going to make is definitely going to check out and is going to evaluate your pathology knowledge as well. So let's get started. And you are very well aware of the fact that the commonest blood cancer in pediatric age group is acute lymphoblastic leukemia. But if he says what is the commonest blood cancer in adult population and he makes it easier for you by writing the word geriatric population, then your answer would be the first topic that we are studying, that is chronic lymphocytic leukemia. However, he can slightly twist the question by saying what is the commonest acute leukemia in adult population, then your answer would be given as acute myeloid leukemia. These are some baseline questions that you need to remember, and then comes an important aspect. Since you are aware of the fact from pathology that majority of cases of CLL initially can be asymptomatic, it might be an incidental diagnosis. Like this is a 70-year-old guy, retired from the army, very fit and fine. He went for an annual medical checkup and his complete blood count report was deranged. He did not understand it, so he brought the report to you. You found his TLC was elevated. In DLC, it was mainly lymphocytes that were increased because you very well know it's basically a B cell lymphocyte tumor. So the question to you guys, and that has an overlap from pathology. In fact, the first slide of mine will have some overlap from pathology, would be that what should be the absolute lymphocyte count, more than how much for how much duration that you would be suspecting that the person could be having chronic lymphocytic leukemia. Then considering the age group of the patient, you need to remember absolute lymphocyte count. If it is more than 5 into 10 raised to power 9 cells per cubic millimeter, or if he says ml in the denominator, it really does not matter, for consecutive 3 months. You see, you have to demonstrate serially that the lymphocyte count of the patient is increased. That would make you suspect in terms of chronic lymphocytic leukemia. Make no mistake that in MCQ he might actually introduce the word atypical lymphocytosis. I said absolute lymphocytosis. He will write atypical lymphocytosis, which is a deliberate wrong statement in the question by the examiner, because atypical lymphocytosis is what you see with the infectious mononucleosis, which is caused by Epstein-Barr virus. Now this is a B cell tumor, but it expresses CD5. You are aware from pathology that CD5 is expressed by T cell, T for tiger, but here CD5 is being expressed by a B cell. So that's why I said this is an abnormal cell. And then is an aspect that is it originating from a mature B cell or is it originating from an immature B cell? You see, in older books and even in older pathology books, it was mentioned that it originates from immature B cell, but that is old information. In the 20th edition of Harrison, he has categorically written, in fact, in the first line of the tumor itself, he said that this is going to be morphologically, immunophenotypically mature appearing lymphocytes. A pathologist can obviously differentiate immature cell from a mature cell. So it is morphologically a mature appearing cell. And even I've checked in Wintro's hematology, where it is written that in 60% of the cases, this would be originating from a mature, that is a memory B cell. Older books used to say naive B cell for the cell of origin. I agree it's a controversial question, but I want to give reference of Harrison here stating that this would be origin of cell will also be mature, and morphologically speaking also, immunophenotypically also, he says this would be morphologically a B cell present. Now, once we have this information in place, though these cells are going to be fragile also, right? When you will make the smear, you will have that classical smudge cells. I'll show you the image of smudge cells subsequently, but these are some aspects which I definitely want you to remember from pathology. And then would be information with respect to ZAP70. Now, whenever we read about ZAP70, zeta-associated protein, first of all, we should be knowing what do you imply by ZAP70? Well, this is an intracellular tyrosine kinase, and this has been found to be present inside the T cells. See, this is present inside the T cells, but in our case, we are describing a B cell tumor which is expressing it. So obviously this is an aberrant expression, but more importantly, over and above the aberrant expression is that you would have read in the book that some patients of CLL might be requiring treatment as early as 3 to 4 years of diagnosis. Like this 70-year-old man, he was diagnosed with CLL in the month of, let me say, January 2022, and he might require treatment by 2025. But in some cases, the treatment might be required after 10 years. That is, the same person required treatment, or in fact, he died before that because of a myocardial infarction even before the treatment for CLL could be started. So the query in the mind of every doctor is that how is it that a tumor is going to be having such a wide variable expression? So what I'm telling you is also a prognostic marker. If you read a patient having CLL diagnosed is ZAP70 positive, this means for you as a clinician, the treatment requirement in this patient will come relatively early. Most of the time, if this is gonna be ZAP70 positive, the treatment would be coming in the next 3 to 4 years. Whereas if you read that it is ZAP70 negative, that would be good prognosis. Person will not require treatment for the next 8 to 11 years. Now you don't need to remember 8 to 11, 3 to 4 years. You just need to remember from the exam perspective, ZAP, if it is 70, if it is given positive, it means that the person is having a bad prognosis. I'm not saying worst. I will tell you when to answer worst prognosis, bad prognosis. And if it is ZAP70 negative, this implies this would be good prognosis. Then another special feature of this tumor will be that it will produce autoantibodies, because see, the problem in this tumor is that this is proliferation of immuno-incompetent B cells. Now when I say incompetent, the first problem is that they are not able to differentiate between self and non-self. Therefore, they might produce antibodies that might be attacking self red blood cells and might be attacking self platelets also. So just for representational purposes, let me say the antibody is causing destruction of RBC. So the MCQ will say Coombs positive hemolytic anemia. And the antibodies can also be contributing to damage to self platelets as well. So normally, whenever you read about a blood cancer, you say or you read that the blood cancer causes a predominant bone marrow involvement, and the bone marrow involvement contributes to anemia and thrombocytopenia. In all blood cancers, the standard information is bone marrow involvement contributes to anemia and thrombocytopenia. But here I'm saying it's going to be a immune mediated, because these incompetent cells will not have the capability to fight with the infection. So you read the leading cause of death in patients of CLL is infection. Most of the time it could be recurrent pneumonia, it could be COVID-19 pneumonia. The number one cause of death in these patients is infection, because cells are incompetent. Adding insult to the injury, these chaps are also attacking self RBCs. So if you read regarding a blood cancer in a geriatric age group where he says Coombs positive hemolytic anemia, autoimmune hemolytic anemia, immune mediated thrombocytopenia contributing to epistaxis or bruises all over the body of this patient, or even a life-threatening bleed, you have to think in terms of chronic lymphocytic leukemia. Now, there is a possibility that he might actually give you a question where the count might be lesser than what I mentioned. I gave you a threshold, right? I gave you a threshold more than 5 into 10 raised to the power 9 cells per cubic ml or cubic millimeter. But here I'm saying, if suppose in the exam he gives you a scenario, the count is less than the threshold. And he also mentions that at the moment there is no lymph node involvement. There is no organomegaly, there is no liver involvement in the patient, there is no spleen involvement in the patient. Traditionally, in all blood cancers, you have organomegaly and a lymphadenopathy. Count is lesser, lymph nodes are not involved, liver and spleen is not involved, and even there is no autoimmune hemolytic anemia that I was talking about in the previous slide. There is no immune mediated thrombocytopenia present in this patient. It is absent cytopenia. This means we are talking about a precursor of this disease. Just like in multiple myeloma in pathology, you would have read about MGUS, monoclonal gammopathy of unknown significance. Then you read about multiple myeloma, you read about smoldering myeloma. Similarly, I'm giving you a spectrum in this case. The spectrum in this case would be answered as MBL, that would be monoclonal B cell lymphocytosis. So because of the fact that he has put up a question like this, therefore I would like you to remember this term also. This is the precursor for development of chronic lymphocytic leukemia. CLL can deteriorate further also. Like in the later part of the discussion, though I'm giving a short explanation even at this moment, you will notice I will say CLL patients can differentiate into diffuse large B-cell lymphoma. Shocking, right? On one hand, I'm saying you could be having a precursor. On the other hand, I'm giving you another extreme info that CLL can deteriorate into the lymph nodes will start growing exponentially. Big cervical lymph nodes could be present and they would be continuously increasing in size. And when I did an excision lymph node biopsy, it revealed that CLL patient has converted into DLBCL. This is, guys, what is called as Richter transformation or Richard transformation. I will be telling you how to identify it and which lymph nodes are to be sampled so that you can identify it as we progress in the discussion. But I have highlighted two aspects here. One, the precursor, and second, the conversion of this into an aggressive lymphoma. One of the highlights again of the disease is you will read in multiple choice questions and in the textbook the word hypogammaglobulinemia. Now, why I chose to mention it is because of two reasons. First of all, a lot of guys just say casually, sir, on one hand you were saying autoimmune hemolytic anemia, now you're saying hypogammaglobulinemia. Yes, guys, both can coexist also. No? There is a possibility that in this chap, the production of IgM is lesser than normal, which makes him more susceptible to development of infections. And I have already told you the leading cause of death in these patients is infection. But at the same time, whatever antibody is being produced, let me say IgG class of antibody, even if it is produced lesser, it is attacking self only. So if I highlight this word once again, which I said earlier, this is the keyword. I mean, if you remember this word that I'm writing, you are understanding the origin of this disease, immunoincompetence. The problems are you don't know how to fight, right? I'm talking about lymphocyte here. The problem with this lymphocyte is, sir, I don't know how to fight. And you are attacking self. You are attacking self red blood cells, you are attacking self platelets. So obviously in these patients, as the disease will progress, bleeding manifestations will occur, a severe pallor will occur. So we will study about how to treat this, but at the moment first would be to answer why is this disease developing in the patient. Now when it comes to the why component, he would love to ask you regarding the chromosomes that are involved and the genes which are involved here. So there are a couple of them which are important versus remembering, so a bit of cramming part here. The commonest chromosomal aberration that you will encounter in these patients would be deletion with respect to chromosome 13q. Second one to be remembered would be trisomy 12. Third one is important because that is related to worst prognosis. Earlier I said bad prognosis. Like I said, if person is ZAP70 positive, he will require treatment within 3 to 4 years. That was bad. But now I'm saying the word worst prognosis. So this is definitely worth remembering for MCQs. Which chromosomal abnormality is related to worst prognosis in chronic myeloid leukemia? Your answer is what I've just highlighted in part number 3, deletion related to chromosome number 17, the short arm. Then can be overexpression of two things. One I've already explained, ZAP70. Second would be overexpression of BCL2. And what's the problem with overexpression of BCL2? The problem is that it will inhibit apoptosis. If you do not have programmed cell death, if the cells will not die, what will they do? There will be uncontrolled replication. There would be uncontrolled mitosis. I mean, cancer is a condition after all of uncontrolled mitosis only. Point number 4 and 5 are simple, straightforward to remember. Anti-BCL, overexpression of BCL2 and then overexpression of ZAP70. And ZAP70, as I explained to you, is a tyrosine kinase which is present in T cells but is expressed on a B cell tumor in this case. Apart from this, they would also love to ask about the genes. So the genes to be remembered would be two of them. One of them would be SF3B1, a bit of tongue twisting names to be remembered. The second one is Notch1. This is easier to remember, and you will notice that in the earlier part of the app I've spoken about Notch1 with valvular heart disease. Which one was it? Valvular aortic stenosis. And in the later part of the app you will notice in neurology I'm talking about Notch3. Notch3 is related to CADASIL, that is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So small vessel stroke. I repeat again, Notch1 has been discussed in cardiology for valvular aortic stenosis. Notch3 has been discussed in neurology with respect to small vessel stroke in the topic of ischemic stroke. So just a overlap from other subjects which I thought I'll just mention here before you. And you will also notice that all the blood cancers are related to radiation exposure, especially with respect to Hiroshima, Nagasaki. People who were not in the bomb zone, they were like, let me say, outside of the city, but they were still exposed to a substantial amount of radiation. So they ended up with development of blood cancer. But one MCQ where they will say, which blood cancer is not related to radiation exposure, then the answer would be the topic that we are studying, chronic lymphocytic leukemia, which expresses T cell markers. The next point is, I would not suggest you to note it down. This is only from the perspective of that it is given in Harrison. And if you watch war movies, especially related to the Vietnam War, you will notice that Americans, they used chemical weapons. I mean, Americans will act as if they're trying to clean the whole world of the weapons of mass destruction, as they call it. But they are the ones who have been rather exporting chemical weapons everywhere. Not that I want to sound political, but this is given in Harrison that they used this chemical Agent Orange. This was mainly to, stain those rebels or to rather force out those rebels from that area. And even if they escape, that Agent Orange would be staining their skin, so they would be picked up. So in the Vietnam War, the Americans used to send in chemical bombs, chemical weapons, which used to deliver this Agent Orange. And therefore, especially in Vietnam, Southeast Asia, there have been higher incidence of CLL, especially post-Vietnam War. And this is given in Harrison, so not that I'm trying to sound any political aspects here or trying to introduce politics here. That's not my objective. Also, you will notice that normally, like let me say, a person would tell you, my father died of a particular cancer. But his elder brother never had a problem, his younger brother also never had a problem, his younger sister never had a problem. But in CLL, you will notice a person will say, my father died of blood cancer, CLL, and his elder brother also developed CLL, and maybe the younger sister also developed CLL when she turned 70. So you will notice highest familial association. Quoting Harrison here, this is the only blood cancer which has a high level of, otherwise familial association we read multiple times. But blood cancer having a familial association where you read that first degree relatives are getting affected, or like this person's father's elder brother and younger sister, when they attained 70-75 years of age, even they developed the same malignancy and expired because of that. So these are a couple of whys that you need to remember for this tumor which has immuno-incompetent cells. And now we will focus on the clinical part. The median age of onset of this disease would be about 71-72 years of age. And if you look at the male to female ratio, you will notice that this is very skewed. Like in SLE, you read 9:1 for female is to male. Here I'm talking about male to female ratio of 7:1. And in majority of cases, 50% of the cases at presentation, as I've highlighted, and you would have read in pathology also, are detected incidentally. Now, obviously, this is more common in Western scenario where annual medical checkup is a norm. Otherwise, in our country, most patients will present in the following fashion to you, that is with category B symptoms. And when I say category B symptoms, it means that the features would be identical to what you read in tuberculosis. So I have this old man who says, doctor, earlier I could go for a morning walk of 5 kilometers, but over the couple of months, I get tired very soon. My weight is also reducing. I'm using the word involuntary weight loss. I want to again quote the textbook here. The cutoff for involuntary weight loss given in Harrison is 5% over 6 months. But listen to my next word very, very carefully. At the moment, I am talking about a hematological malignancy where they use the word category B. Whenever you read the word category B or whenever you're talking about hematological malignancy, the cutoff changes to 10% over 6 months. I repeat again. IWL, involuntary weight loss. If you read the chapter, it's a separate chapter in Harrison, volume 1, and it is mentioned in the first 2 lines of involuntary weight loss. It is 5% of weight loss over 6 months. But if he says category B, it's gonna be 10% to call it a substantial or a significant weight loss. And then another feature that you will notice in this patient would be night sweat. So initially, when you read this question, you might be thinking that I am reading a description of patient of tuberculosis, and especially in old age group, possibility of tuberculosis can very much be there. This will further be rather cemented by the fact that there is a cervical lymphadenopathy. The lymph nodes of these patients will keep on increasing in size, and some of these patients might be erroneously be started on ATT also, but the lymph nodes will still continue to increase in size. Also, if the spleen begins to increase in these patients, the enlarged spleen will press on the stomach. Therefore, this person says that I also don't feel like eating, doctor, like my weight is reducing, so I thought that I should eat more chapatis or I should eat more rice, but I eat 1 chapati or 2 chapatis and I feel full. That's because of the enlarged spleen pressing on the stomach of this patient. Because of the immuno-incompetence component, this person might have been hospitalized in your hospital a couple of times, and his son is also asking you also, sir, why is it that my father has developed 2 pneumonia episodes, or maybe last winter and this winter he has been admitted, and it was the severe variety of pneumonia, and if it is COVID-19 pneumonia, then even more problems would be seen. Apart from recurrent pneumonia, there could be reactivation of chickenpox. So he could describe that this old man is having blisters, rather he will say painful blisters in dermatomal distribution. You very well know that in herpes zoster, the appearance of blisters would be in one single line, one after the other. They would be horribly painful. There would be substantial amount of neuralgia present. And in fact, this is a very good pickup point in the MCQ for herpes zoster, dermatomal distribution of painful blisters. That makes it relatively easier for you to pick up. Apart from this, these patients can be having anemia. See, I'll say 2 things for anemia here. if the disease will progress, it will obviously cause bone marrow involvement, and bone marrow involvement will contribute to anemia. But because in these patients, initially anemia can be present even before significant bone marrow involvement. Normally, a cancer causes substantial bone marrow involvement, you get anemia. Here, even without a substantial bone marrow involvement, you can be having a development of anemia because of autoantibodies. So there would be Coombs positive hemolytic anemia, but don't be surprised if in a multiple choice question he mentions Coombs negative hemolytic anemia for this patient. Why? Because if it is turning out to be Coombs negative, it means that he's trying to tell you indirectly that this has now caused a bone marrow involvement. So there are two reasons for anemia. I reiterate once again, bone marrow involvement, obviously late phase, but you can have a AIHA also present. So both types of anemia, Coombs positive, Coombs negative, can be present in these patients. The immune mediated thrombocytopenia in these patients can contribute to development of petechiae. Most of the time these petechiae will be developing around the ankles of the patient. Then subsequently the person will be having purpura. Purpura means palpable bleed in the skin, and this could then translate subsequently into visible bleeding in the form of epistaxis, and organomegaly will anyway be seen. So you will read about hepatosplenomegaly. I have in the subsequent part of the app highlighted that if you read regarding splenohepatomegaly, there are two disorders that you should be remembering from splenohepatomegaly perspective. You don't need to note down what I'm saying at the moment because this is just an accessory info. Two diseases where you read about substantial splenohepatomegaly. One would be myelofibrosis and another would be thalassemia. Because you have extramedullary hematopoiesis present in these patients. I mean, you will also say, sir, what's the difference between hepatosplenomegaly and splenohepatomegaly? It's only that in splenohepatomegaly, spleen size is bigger than liver. Hepatosplenomegaly, liver size is bigger than the spleen. But overall, I mean, if after all they mean the same only, but it is just a difference in the size of the organ per se with respect to another one. And two differentials that I've highlighted for splenohepatomegaly are anyway to be remembered for the questions part. Now coming to the workup of these patients, the first investigation that we'll be doing here would be a complete blood count. In the initial part of the disease, total leukocyte count would be elevated. I've already explained to you regarding absolute lymphocytosis. As autoimmune hemolytic anemia kicks in, there would be low hemoglobin and also thrombocytopenia in these patients. When I check out the peripheral smear of this patient, what I will find is that these mature looking lymphocytes are highly fragile, so they can make while preparation of the smear, and therefore one of the characteristic features that you will notice will be a distorted cell, which I can just zoom in for your convenience, and therefore we will be having presence of smudge cells. Another feature of autoimmune hemolytic anemia may or may not be seen in the smear, but still we should be remembering it. That would be presence of spherocytes. Well, how would you pick up a spherocyte on a peripheral smear? Simple and straightforward. Normal RBCs always have a central pallor. You can see that the inside of the RBC will always be appearing blank or white. But spherocytes, there is no central pallor that is present. They're obviously relatively smaller, and at the same time there is no central pallor present. So whenever you read about spherocytes in pediatric age group, obviously we are talking about hereditary spherocytosis, but in internal medicine, when you read about spherocytes, you have to always think in terms of autoimmune hemolytic anemia. The diagnosis of this condition is fairly simple nowadays. On a blood sample itself, we can be running flow cytometry, and then there will be certain markers that will be written in the question which will confirm the fact that the clinical diagnosis of yours for CLL was fine. Let us see what the report will say. The questions will say CD19 positive, CD20 positive, CD23, and then CD5 positivity. I have already sensitized you to the fact that this CD5 is expressed on T cells, and here it's a B cell tumor expressing a T cell. However, while attempting questions, you have to be a little more careful because he might be doing slight variations. So please notice the slight variation that I'm mentioning at the moment, that the tumor that I'm mentioning now is a differential diagnosis, which is to be remembered because of the fact that this particular tumor can originate from the mantle cell of lymph nodes, and a differential diagnosis of this condition can be mantle cell lymphoma. I repeat my fact, the origin cell that I was talking about is initially found in the mantle cell of the lymph nodes, and then there's another tumor by the name of mantle cell lymphoma. So what is he gonna say in the MCQ? CD23 will not be mentioned. He will say CD5 positivity and cyclin D1 positivity. If this is the information given in the question, then you will change your question's answer to that of mantle cell lymphoma. So because mantle cell lymphoma will also be having a lymphadenopathy, So do not rely only on the clinical presentation. I mean, obviously, old age group with autoimmune hemolytic anemia, I said there are certain markers for CLL, but then flow cytometry report will definitely make it easier for you. So let's try to do it once again, and I'll just modulate the information once again. CD19 and 20 will be common to all these discussions. In fact, when you check out a table in Harrison or in Robbins, you would have read this information that I'm talking about at the moment, but it is given in a fashion which is difficult to remember. So what I am trying to do here is write CD19, 20 again and again, so that you can also notice that in mantle cell lymphoma, CD23 had disappeared. Now CD23 has made its appearance, but there will be no mention of CD5 and there will be no mention of cyclin D1. So the answer will change once again. Please appreciate the difference between the second and the third entry. In the second entry, CD23 is missing. In the third entry that I'm mentioning, it is CD5 and cyclin D1, which were present in the second entry that are missing. An extra point present here is CD10. Then you are going to change your answer to that of follicular lymphoma. This is a table which is given in Harrison, and this has been, I would say, repeatedly asked in the exam. He will give you a question that will look very longish. He will mention a lot of clinical details, and people tend to get lost on those clinical details, whereas all you need to do is focus on the third or the fourth line of that clinical long stem question where these flow cytometric markers are given. So I would rate this particular part of the discussion that I'm making at the moment as the most relevant MCQ wise section of the discussion. I mean, if you get this right, you would be able to score in those really long clinical stem questions. Other investigations that will be done by me for these patients would be to check out the values of immunoglobulin G, because I have already told you that these patients would be having hypogammaglobulinemia. I will also be doing a complete metabolic profile in this old patient. I want to check out the lipids, the blood sugar, because there could be comorbidities present in these patients. See, if a person is 75 years of age, he's having triple vessel disease, he's having benign prostatic hyperplasia, he's a diabetic also. So in those circumstances, he may not be fit enough to tolerate the myelosuppression caused by your anti-cancer drugs. So it's not that I will start anti-cancer drugs in everybody. I will check out for the comorbidity factors. I will check out whether this person has the capability, or I can, if I put it casually, strength to handle anti-cancer drugs, because starting chemotherapy is not a joke. After all, the person will have to endure a lot of side effects also. So we always check out complete metabolic profile of these patients and check out the comorbidities of these patients so that they are able to handle the chemotherapy component relatively better. Now, there's also a possibility that the lymph nodes of these patients are progressively increasing in size. If they are progressively increasing in size, what I will do is I will be doing a FDG PET DOPA in this patient, or FDG PET, and on basis of this FDG PET report, I'll be able to select which group of lymph nodes is growing the fastest. From that, I can go in for excision biopsy of this significantly enlarged lymph node. My objective is to detect that Richter transformation that I was mentioning earlier. So they have asked two aspects. One, they have simply asked that what is the Richter transformation in CLL? The answer is conversion to DLBCL. And second is, how would you diagnose it? So it would be initially a PET scan being done in the patient to identify, I mean, the multiple lymph nodes which are present, which could be involved in these patients, and a couple of groups could be growing much faster as compared to others. So I need to select the site of whichever site in the body would I be preferring a excision lymph node biopsy, and once I've done it, I can detect it, and subsequent management can be done. Now, for deciding the treatment of these patients, we shall be using an understanding staging like we do for any cancer. There are two systems available. One is called as Rai-Savetsky classification. The second one is called as Binet's classification. I will be discussing them side on so that we can remember the aspects related to each one of them. In Rai-Savetsky, you will notice that he will mention details like a patient is low risk versus intermediate risk versus high risk. And the categorization on the right hand side in Binet classification would be A, B, and C. So let's have a look at the side on comparison. In low risk, he will say this person has been detected with lymphocytosis. I already mentioned the cutoff values before you. It's absolute lymphocytosis. But if you are going to be having a combination of lymphocytosis with lymphadenopathy, it may not be cervical, it could be another group of lymph nodes also. We'll classify this patient as intermediate risk. About 50% of cases might be actually belonging to this intermediate risk when the treatment is being started. Along with this, additional feature may or may not be present, that is hepatosplenomegaly. So it's mainly lymphadenopathy to be remembered. Liver and spleen enlargement may or may not be present. For high risk, he will mention lymphocytosis, and along with this, there would be development of anemia, and then would also be petechiae because of the thrombocytopenia. Now, what you to understand at this point of time is that this anemia and thrombocytopenia that I am explaining to you at the moment is not that autoimmune component. Yes, that autoimmune component can be present early also, but at the moment he says you will classify this person as high risk if the anemia and thrombocytopenia is because of bone marrow involvement. I've already explained to you there can be two reasons for anemia: early part autoimmune hemolytic anemia, but subsequently the clonal expansion of the immunocompetent cells. The cells will colonize whole of the bone marrow, so megakaryocytes will not have space to multiply. The normoblasts will not have space to multiply. So this is disease related bone marrow involvement which is contributing to anemia and thrombocytopenia. Binet is relatively easy. He says less than 3 areas of lymph node enlargement. Whereas if it's gonna be equal to or more than 3 areas of lymph node enlargement, then it would be categorization as B. And for C, he says that you are able to document that there is anemia in the patient and the platelet count is less than 1 lakh. They obviously, keep on, sometimes they use in 10 raised to power 9, sometimes they are using values from the Indian perspective. So I have just tried to give you the routine information that is given with respect to staging, both for the Rai and the Binet classification. And now we will decide what is the treatment to be given. Now, how on the basis of this classification would you be deciding as a physician that there is a need for treatment? This is the second most important part of this discussion, because I think remaining aspects have been studied in pathology also. So when would I decide that a person is having requirement of treatment? One would be, I would say, a high risk patient. So if there's a progressive marrow involvement, if there's a progressive bone marrow failure occurring in the person, I definitely need to start treatment which is in the form of chemotherapy. I'll describe the chemotherapeutic drugs for you as well. And I would like to once again highlight this fact that he mentions in the textbook that anemia and thrombocytopenia that is occurring in this patient is not due to autoimmune destruction, because if it is autoimmune hemolytic anemia, you can give steroids also, no? That's relatively easy to manage, but bone marrow involvement, you definitely need to use chemotherapeutic drugs for the patient. The second important feature is that the person is having a massive splenomegaly. Now we read this term multiple times, but what is the cutoff value of massive splenomegaly? So you need to remember a value here that would be at least the spleen is 6 centimeter below the costal margin. I did not say spleen 6 centimeter. I said spleen palpable 6 centimeter below the costal margin. He says also if it is symptomatic splenomegaly. I've already explained to you that if a person is having enlarged spleen of this particular size, then this would be compressing the stomach also, so he would be having early satiety coming up. The next statement to be remembered is massive lymphadenopathy in a patient. So there's a progressive cervical lymphadenopathy, and maybe he was erroneously diagnosed as a case of TB. He was taking antitubercular treatment also, but the lymph nodes are increasing. What is the definition of massive lymphadenopathy in CLL? It is lymph node size which would be more than 10 centimeter. Then is autoimmune. Listen to this part carefully. It is an autoimmune hemolytic anemia. He might say Coombs positive hemolytic anemia, which is non-responsive to steroid therapy. In point number 1, I said it is predominantly a bone marrow involvement that is occurring, but at the moment I'm saying if it is autoimmune hemolytic anemia which is not responding to steroid, then this is definitely, an indication why you should be starting treatment in the patient, and then could be some costal symptoms also. Now, point number 5 is very subjective, but still, let us assume that this person of CLL has developed fever for previous 2 weeks and you have not found any focus of infection. It is malignancy which is responsible for production of cytokines like interleukin-1, and that is contributing to development of this fever in this patient. The fever is also not low grade. It is more than 100 degree Fahrenheit, and obviously a person will get irritated because of this continuous fever, or there is a significant unintentional weight loss. I have already given you the definitions, but point number 5 is a little subjective, but the initial points that I mentioned before you, I would say they are much more relevant for decision making whether you should start therapy in a patient or not. Coming to the treatment of this patient, there can be 2 situations. One, in the MCQ he could mention a relatively younger patient. He is less than 65 years of age. and there is no comorbidity present. Second would be a patient more than 65 with presence of comorbidity. So let's look at the difference in the chemotherapeutic drugs that you will be using for this patient. Your answer for the first situation will be FCR. In the older edition of the app, you will notice I also spoke about PCR, that is pentostatin, cyclophosphamide and rituximab. But in this version, I'm talking about only the one that is given in the current books, that is FCR. F would be standing for fludarabine. And I put a star mark just to highlight that this would be the single best answer for drug of choice for chronic lymphocytic leukemia. C would be standing for cyclophosphamide. Yes, that causes hemorrhagic cystitis. So a couple of side effects of anti-cancer drugs can definitely be asked to you, and the anti-CD20 molecule that would be used here is rituximab. This is the chemotherapeutic approach that you'll be using for this relatively younger patient. Now, if he mentions comorbidity, by comorbidity, I do not mean a very frail man. If I say extremely frail man with triple vessel disease, who's also having alcoholic cirrhosis, also having diabetes mellitus, also having a large prostate, I might decide not to start chemotherapy. But here I'm saying, okay, there is a comorbidity like hypertension. There could be a comorbidity like a presence of diabetes mellitus, but HbA1c of the patient is well controlled with the usage of anti-diabetic drugs. So the chemotherapeutic agent that I'll be using for this patient would be slightly different. One of the drugs that we'll be using here is chlorambucil, and second would be a monoclonal antibody. I mean, there's no limit to the names of monoclonal antibodies that you need to remember. So a slightly tongue twisting name here, that is obinutuzumab. These are, I mean, there's a whole list given actually in the book. So what I've selected are the primary answers that you need to give: FCR and CO, that would be chlorambucil and obinutuzumab for management of these patients. Alternative drugs are also given. So if you are interested in remembering this is something that is just optional. But I mean, since there's an entire list given, so I'm just mentioning one more combination, that is bendamustine with rituximab. Most of the time in the exam, he might decide to ask you from any of these combinations. Over and above this, he can also ask about a couple of other approaches that can be useful for management of these patients, like anti-apoptotic drug, which is by the name of venetoclax. You are definitely gonna read about this in pharmacology also. And since it's a B cell tumor, so we would like to use some other drugs which are selectively going to act on the B cells only. You see, I can put it like this: you have a special commando team that goes in and kills only the terrorists, so that the bad guys are killed and the good guys are perfectly fine. Similarly here, that I am talking at the moment are B cell signaling inhibitors. These are specialized drugs which will be specifically affecting those cells of chronic lymphocytic leukemia and would not be causing any damage to the adjacent cells which are present in the bone marrow. And there are two of them that you need to remember. The first one is ibrutinib. This is a Bruton tyrosine kinase inhibitor, and the second one to be remembered here is idelalisib. These are two B cell signaling inhibitors which are to be remembered over and above the initial chemotherapeutic regimens for management of this patient. And next I'll describe before you how will we come to know whether patient is having a clinical improvement with the administration of these drugs, and then I'll describe complications of the disease. First of the parameters that will tell me that there is a clinical remission occurring in the patient would be that the absolute lymphocyte count is reducing. At the moment, I'm saying absolute lymphocyte count. Total TLC is less than 4,000 to 11,000. If the absolute lymphocyte count is less than 4,000 per microliter, that tells me that my person is responding to my chemotherapeutic approach. Initially, when he came, lymph nodes were more than 10 centimeter in size. Now, all the lymph nodes we have measured, and all the lymph nodes have been determined to be less than 1.5 centimeter. The liver and the spleen of the patient, which were initially enlarged, hepatosplenomegaly was present, now they are non-palpable. The fourth feature which tells you about clinical remission would be that there is a bone marrow improvement in the patient. You see, you don't need to do a bone marrow in these patients for diagnostic purposes. Flow cytometry is more than sufficient. But to check the response, whether the person has responded to your treatment or not, subsequently a bone marrow can be done. And a normocellular bone marrow would tell you that you have got rid of the bad guys which are present here. The platelet count of the patient is persistently more than 1 lakh per cubic millimeter. Also, the hemoglobin component is more than 11 grams. So if the following points are present, this tells you the fact that there is a clinical resolution or clinical remission that is occurring in this patient. Let's also quickly revise the important complications of chronic lymphocytic leukemia that I have mentioned at various stages during this entire discussion, but I can just put them at one place. So what I'm saying at the moment, this would be a slight repetition, but still worth the effort. There can definitely be infections in these patients. One of the reason would be hypogammaglobulinemia, and second is the aspect of immuno-incompetent cells having a clonal expansion, so these guys do not know how to fight an infection. Then is the aspect of secondary malignancy. This is a new point. You see, secondary malignancy traditionally means that you are giving some anti-cancer drug to the patient for treatment of a particular cancer, and then he ends up with development of a new cancer. The concept of secondary malignancy I have specially discussed in acute myeloid leukemia as well, so I want you to listen to secondary malignancy component in acute myeloid leukemia also. But at the moment I am saying that the secondary malignancy which I am talking about in CLL is not due to anti-cancer drugs. It is not that for treatment of any blood cancer I gave an anti-cancer treatment, it is causing a secondary cancer. All I'm saying is that what we have found in CLL patients on serial follow-up is that they have an increased incidence of skin cancer as well as prostate cancer. On listening to this, you will say, sir, what is the big deal? I mean, prostate cancer is anyway common in old people. Skin cancer is already common in older people, especially in Western population. So what's the big deal? What we have found is that the incidence of skin cancer and prostate cancer can be up to 10 times of what is found in old population. Whatever is the baseline rate of prostate cancer in India, whatever is the baseline rate of skin cancer in India, up to 10 times more incidence of these cancers can be seen in people who are already having a CLL. So we need to tell these patients regarding the symptoms of these particular diseases as well. Then is autoimmune mediated damage. I've already explained that there can be autoimmune hemolytic anemia, but studies have shown that there can be autoimmune glomerulonephritis also developing, autoimmune vasculitis also occurring, and autoimmune hemolytic anemia has already been discussed in the earlier part of the discussion. However, in MCQs, instead of writing autoimmune hemolytic anemia, the examiner can write the following aspects. Because it is warm antibody mediated, he can quiz you about that. I've already told you it would be Coombs positive hemolytic anemia. If RBCs will get destroyed, then bilirubin values will increase in the patient. RBCs will break, so LDH values will increase, and to bind to hemoglobin, we have haptoglobin present in the blood. Whenever there's gonna be hemolysis, haptoglobin is gonna be consumed, so haptoglobin values will be relatively lesser. So instead of writing AIHA, the examiner can write these lab reports in the question. For a person of CLL, elevated BIL, elevated LDH, haptoglobin less, he's indirectly trying to tell you that there is a AIHA present in the patient. This will definitely respond to steroids. Apart from this, even immune mediated thrombocytopenia can be occurring in these patients, and therefore what I need to do is start this person on steroids. Now there's also a possibility that he might ask about a classical name where you could be having these two things together. You are aware from pathology a condition that is referred by the name of Ivan syndrome. Ivan syndrome is presence of concomitant autoimmune hemolytic anemia as well as immune mediated thrombocytopenia in a patient, and if this is non-responsive to steroids, if both of them, giving steroids is not causing raising of platelet count, you will anyway have to decide to start giving chemotherapy, and that chemotherapy decision will be based on the age of the patient, presence of the comorbidities, and also about these special aspects which are highlighted. Especially, I mean, this is a very special table, I would say, which decides whether you should be treating a patient of CLL or not. And there's also great disparity with respect to expression of zeta associated protein ZAP70, because if ZAP70 is going to be present, treatment will be required earlier. If it is negative, I told you the treatment might be delayed by as much as 10 years. Another complication worth mentioning just for record's sake, and would be the last point of this discussion, is Richter transformation. Aspects related to it, I've already explained. What is the cancer that's going to develop here? Diffuse large B-cell lymphoma. How am I going to decide which lymph node to go for excision lymph node biopsy? FDG PET scan, and once the diagnosis is made, I mean, this guy will anyway be then treated on the lines of a non-Hodgkin's lymphoma, and treatment of non-Hodgkin's lymphoma is discussed separately, serially, subsequently, and fairly in the app. So these are the details from the medicine perspective that I would like you to remember for this topic. Keep learning, guys. One topic a day makes you stronger, makes you mentally more stronger, I would say. Keep hammering, keep the focus on, and you will definitely cross over to the other side. What I mean by crossing over is you will get great marks and great ranks. Thanks for your time and patience and hearing me out.